Acute renal failure. Abnormal renal function, identified by a high creatinine or oliguria, less than 30 ml/hour, is a frequent and caused by a wide range of processes. When it develops over hours or days, the term acute renal failure is used. Etiology and pathophysiology. Acute renal failure, ARF, can be caused by a problem anywhere from the renal artery to the urethra. It is useful to classify ARF according to where the principal problem is, prerenal, renal, or postrenal, Fig 22. Epidemiology. Transient renal dysfunction occurs in up to 5% of hospital admissions. In the UK, severe ARF, a reversible increase in creatinine greater than 500 moles/L, has an incidence of about 140 per million population per year. Clinical presentation. Usually ARF is diagnosed on the basis of elevated plasma creatinine, or when oliguria develops in a patient whose urine output is being monitored reliably, e.g. catheterist. Sometimes the presentation will be a direct consequence of the renal failure, e.g. fluid overload or acidosis, but usually features of the underlying condition predominate. Immediate consideration must be given to whether dialysis, or another intervention, is required urgently. A circulatory assessment is essential. In glomerulonephritis, there may be a nephritic presentation, i.e. the combination of oliguria, hypertension, edema, and hematuria. NB. Renal failure does not usually cause specific symptoms. Have a high index of suspicion for any patient who is unwell for any reason and have a low threshold for measuring plasma creatinine. Investigations. To assess severity and danger, the following are appropriate in all cases of ARF. Serum potassium and ECG, hyperkalemia. Blood gases, PO2 and pH, oxygenation and acidosis. CXR, pulmonary edema and others. To determine the cause of the renal failure, examine the urine, blood, protein, and casts. Renal ultrasonography, obstruction. Obtain results of any previous blood tests to prove that renal failure is acute. Further investigations will be guided by the clinical setting. Many cases of ARF will merit renal biopsy to establish the diagnosis. Specific diagnoses. Acute tubular necrosis, ATN. Often the cause of ARF is prerenal failure/ATN. A renal biopsy will be performed only if there is doubt about the diagnosis. Obstructive uropathy will usually be diagnosed on ultrasonography. Be aware that occasionally rapid onset obstructive uropathy, especially if the patient is volume depleted, may not result in hydronephrosis. Suspected renovascular disease/occlusion or renal vein thrombosis, magnetic resonance angiography or digital subtraction X-ray angiography is the preferred investigation if a case of renal failure might be the result of renal artery occlusion/stenosis or renal vein thrombosis, usually in a patient with nephrotic syndrome. Blood tests will be helpful in certain settings, and in some circumstances will mean that a biopsy is not required, e.g. hemolytic uremic syndrome, disseminated intravascular coagulation and rhabdomyolysis. Treatment. Urgent attention is given to maintaining oxygenation and circulation. Determine whether immediate renal replacement is required. NB. Indications for renal replacement therapy. Hyperkalemia, K greater than 6.5 mol/L. Seriousness is best evaluated by ECG, Fig 23. Fluid overload not responsive to diuretic. Acidosis. Generally if urea greater than 40 mol/L, certainly if greater than 50 mols/L. ARF is frequently a manifestation of a very serious systemic illness. Sometimes, for instance in the setting of disseminated malignancy, dialysis is technically feasible but may not be appropriate. Supportive treatment. Optimize the circulation. If the lungs are clear on auscultation, give fluid rapidly until the JVP is seen easily, then stop and review the situation. Treat infection. Avoid further renal insults, e.g. hypotension and nephrotoxic drugs. Maintain nutrition, enteral or parenteral if necessary. Monitor fluid balance, input/output charts and daily weighing. Monitor renal function, biochemistry and urine output. Renal replacement if necessary. Prognosis. The mortality rate is about 40% in those requiring renal replacement therapy for ARF. It is much better when renal failure is not associated with other organ failure.